So first let's talk about cardiac contraction with a brief review of contraction physiology. So there are two physiological determinants of cardiac contraction which, simplified, are number one, the intrinsic contraction ability, which comes from the nerve stimulation and release of calcium. So myocardial contraction is stimulated by sympathetic nerve fibers, which stimulate membrane depolarization, which triggers calcium voltage-gated calcium channels, which are in the T-tubules, which then induce calcium release. Calcium release then drives the ability of the myosin light chains to allow the myocyte to contract. The second component, the important physiologic item of note here is that in children, the number of sympathetic fibers increase with increasing age. This is one of the reasons why neonates are dependent on heart rate for cardiac output. Also, why an immature heart has limited response to cardiotonic meds, has a high non-contractile content, and decreased availability of releasable norepinephrine. Overall, the less mature sympathetic system contributes to this, as well as underdeveloped intracellular calcium regulation and stores. Overall, it's important to remember in our neonates and infants that they have greatly decreased functional reserve capacity, which is one of the reasons why in congenital heart disease post-surgically, patients receive ample calcium supply in their postoperative and intraoperative recovery. The second determinant of cardiac contractility, it leads us to a discussion of preload. Preload equals end diastolic volume and is related to right atrial pressure. Venous return to the right side of the heart causes end diastolic volume to increase and stretches and lengthens the ventricular muscle fibers. This is known as the Frank-Starling relationship. The passive stiffness of the heart, the extracellular matrix, and the cellular support structures limit the amount of stretching and lengthening, which makes sure that the sarcomeres do not overstretch so that cross-bridge formation can always occur with the next depolarization. Simple mechanics then in a healthy intact system dictate that up to the confines of ability to relax during diastole, increases in preload will increase stroke volume, thereby increasing cardiac output. Remembering that cardiac output equals heart rate times stroke volume. Afterload, our next component, is divided into left ventricular afterload and right ventricular afterload. Left ventricular afterload is our aortic pressure. Right ventricular afterload is pulmonary artery pressure. Left ventricular afterload is dependent on the dynamic capacitance and resistance of our circulatory system. Circulatory contraction relaxation occurs via smooth muscles. Again, we see the importance of calcium. Vasoconstriction is caused when calcium triggers vascular smooth muscle and initiates phosphorylation of myosin light chains, just like in the cardiac tissues. Vasodilation occurs via increased intracellular C-amp, which increases the intracellular calcium requirement for contraction, thus encouraging smooth muscle relaxation and vasodilation. Since we're talking about the circuitry, we also have to consider some other physical components. The first of which is the velocity of blood flow. The velocity of blood flow is going to equal the blood flow across the cross-sectional area. Herein lies part of the component of capacitance versus resistance. In our large vessels, the cross-sectional area is relatively small and velocity of blood flow will be much faster. In our smaller vessels, there is a greatly increased cross-sectional area, which decreases the velocity of the flow. The velocity then is directly proportional to the flow and inversely proportional to the cross-sectional area. High in the arteries and low in the capillaries. The next component we need to consider in afterload is the blood flow or the cardiac output. This can be defined as pressure, the mean arterial change in pressure, the mean arterial pressure minus the right atrial pressure divided by total peripheral resistance. Two things will drive this. A pressure gradient will drive blood flow. And flow is inversely proportional to resistance of the blood vessels. Resistance, then, is our next important factor to consider. The physical definition of resistance is 8 times the viscosity of blood times the length divided by pi times the radius to the 4th. If you remember from physics, this essentially means that changing the viscosity of the blood or the length of the system will change your resistance by a factor of 2. But if you change the radius of your artery or capillary, you're going to increase by a factor of to the 4th power, which will be a factor of 16. So in definition, resistance is directly proportional to viscosity, which can come into play when you have an increased hematocrit, and resistance is inversely proportional to the 4th power of the vessel radius. In a system of fluids, we also need to consider laminar flow versus turbulent flow. Laminar flow and turbulent flow is contributed to by something called the Reynolds number. The Reynolds number predicts whether blood flow will be laminar or turbulent. If you increase the Reynolds number, you'll increase your turbulence. Things such as decreased viscosity, such as occurs with anemia or decreased hematocrit, or increased viscosity, which can occur with narrowing of a vessel or increasing hematocrit. The final thing to consider in regards to preload is our capacitance or our compliance. This is defined by the distensibility of blood vessels. Which is inversely related to the stiffness. Which means that it's higher in the veins than in the arteries, which makes sense, since arteries have smooth muscle for active vasoconstriction, whereas veins are thinner with fewer components and are less stiff because of this. So less stiffness is going to allow for greater compliance and capacitance. By mathematical equation, capacitance equals volume divided by pressure. So our veins typically hold a large volume at a very low pressure. If you're thinking about this and how it relates to preload altogether, you just have to put it together, into afterload altogether. You just have to think of it all as all the different components that can affect the pressure for the left ventricle as it's pumping out to the systemic system. If your arteries are vasoconstricted, you're going to have a smaller diameter, which is going to increase your pressure. It's also going to have the propensity to cause, for example, you'll have faster velocity of blood flow with higher resistance, and with narrowing, you can also have more turbulent flow, which can also increase your resistance. So they all come together in terms of a final picture of the afterload on the left ventricle. So let's talk about the pressure volume analysis and the integration of the pump and the circuit all together. So I'm sure we all remember this picture from medical school, just reminding us that in monitoring, you can associate the systems together in terms of pressure gradients, volumes, your venous pulse pressures, and your EKG function. So pressure volume curves can be used to discuss the integration of these systems, which to all take into account our intrinsic contractility of the pump, which can be influenced by the nervous system. That's our ionotropic effect, our preload, and as discussed, our afterload. The goal of all of this is to understand cardiac output manipulation to meet the oxygen demands of the body's tissue and to have a basis of understanding how pathology can derange the system and cause end organ dysfunction when cardiac output cannot adequately deliver oxygen to the tissues in critical patients. So we already know that cardiac output equals stroke volume times heart rate. Stroke volume is equal to our end diastolic volume minus our end systolic volume. Ejection fraction is stroke volume divided by our end diastolic volume. In children, ejection fraction is approximately 67%. So let's look at the pressure-volume relationship internally in the heart. Cardiac contraction begins at end diastole and isovolemic contraction proceeds. So we have end diastole, where our mitral valve closes. The cardiac myocytes contract, and initially there's no change in volume, which drives up our pressure until our aortic valve opens, allowing decrease in volume as the ventricle empties. Ejection is then going to continue through maximal elastance, which is our end systole, until the aortic valve closes. With both valves, both mitral and aortic closed, you now have isovolemic relaxation until the mitral valve opens. After the valve opens, you have passive filling of the ventricle, and then you have atrial contraction or your atrial kick, which generates your active filling until end diastole, and then the next contraction begins. This is why stroke volume or cardiac output can be seen to be related to our right atrial pressure or end diastolic volume. This is why we consider this our preload. At any given right atrial pressure or end diastolic stroke volume or end diastolic volume, stroke volume can be manipulated by ionotropic effect, which is under intrinsic cardiac control. So just to review, because this is very important and can be very confusing, at any given right atrial pressure, which is also our end diastolic volume, stroke volume can be manipulated. Which is our intrinsic cardiac control. So primary ionotropy in the heart is augmented through beta-1 receptors, which cause increase in inward calcium influx during the plateau of each cardiac action potential. Included in your lecture notes are two charts, one of which shows the sites of endogenous catecholamine receptors and their effects. In the heart, we see that the sinus node, the receptor type, is primary beta, and our stimulation, which increases our ability to manipulate our stroke volume, remembering that cardiac output equals stroke volume times heart rate. So we can manipulate this part of the curve with beta receptors by increasing our heart rate. Our AV node is also under beta-1 control, atria and ventricles are beta 1, whereas the periphery is primarily under alpha with some beta 2 control. The agents we typically give exogenously, or our ionotropes and vasodilators, are known to act at certain places, certain receptors in both the cardiac and cardiovascular tissue, and then manipulate our hemodynamic effects in various ways, either by affecting cardiac output, contractility, systemic vascular resistance, mean arterial pressure, or our pulmonary capillary wedge pressure, or our heart rate. These are included in your lecture notes for further review. So right atrial pressure, we go back to talking about our preload and how it relates to our cardiac output as well as our afterload, is directly related, when it all comes together, to our venous return or our central venous pressure. So right atrial pressure is directly related to our venous return or CVP. If you think back, remember this is because the two circuits have to be equal. The right heart output and the left heart output are linked and are equal. So by this thought process, increasing our CVP or our venous return will increase our cardiac output. That's the preload portion of the Starling effect. If you increase the volume and the stretch on the myocytes up to a certain plateau, you'll increase the amount of blood that the heart will pump out, increasing our stroke volume. Increased venous capacitance, on the other hand, will decrease our venous return. So if you vasodilate and you increase venous capacitance, you'll decrease return, decreasing our venous volume, and thereby decreasing our ultimate preload, which will decrease our stroke volume. Decreased venous capacitance, then, or vasoconstriction, the opposite effect, will increase the venous return or increase our venous capacitance. Additionally, we have to remember we also have to think about resistance. And this is our afterload. So this is our preload part of the equation, and our afterload part of the equation will also affect our cardiac output. And we remember that left ventricular afterload is aortic pressure, and if you increase your pressure or your resistance, you're going to decrease your cardiac output. As we just talked about, our capacitance and resistance can be manipulated by our endogenous nervous system as well as exogenously by ourselves when we're taking care of critical patients and trying to restore their cardiovascular physiology towards normal. So we put this all together. One of the better ways to think about it is to look at it on a combined graph. So on the bottom, we have our right atrial pressure, or our end diastolic volume. And on the vertical axis, we have cardiac output, which is equal to our venous return because both systems have to be equal. In the middle, you see that we have a balanced system where the venous return then the cardiac output crosses the right atrial pressure and end diastolic volume, where cardiac output and venous return equal each other. If we consider various pathologies, we can start by thinking about something simple like increasing our total peripheral resistance after having hemorrhage. So if you decrease your venous return, you decrease your volume, and you have to increase your total peripheral resistance to bring your system back up to equal. By increasing your total peripheral resistance, you contract, sending more volume back to the heart, which will help bring your cardiac output back to an equal state. If you have increased blood volume, for example, during exercise, when you have increased return to the heart, you want to decrease your total peripheral resistance, improving your capacitance, did I say that?